It's okay.
Hello, ma. Now I'm online. I'm already sharing this link.
Although, èmi fẹ́ ṣe meeting ni mo gbé lọ later. Èmi ti jẹun.
Hello,
Hello,
good
good
morning, ma.
morning. Okay, good
Good
morning.
mo- Good morning,
I
ma.
just want to be sure that I'm on. Good morning, Suleiman.
Good morning, ma. It's my own that is showing from Sulema. I don't know what happened.
Good morning, Nafisa.
Yes,
How
ma.
are you?
Fine, ma.
Sanu, well
He used
done.
my system to do one presentation, so his name is still showing. I don't know.
He's still
Um,
showing.
Let me try and change.
Yes, welcome. Uh,
Or if you're late, you can put it in that takeaway now. Use
Hello, good morning, everyone. Good morning. Please, can you hear me? Confirm you can hear me.
Yes, ma'am. Good morning.
Good morning, ma.
Good morning, ma.
Yes, good morning. Welcome to today's training session. Please, let's say opening prayer in our respective faith. 1 minute of opening prayer, please. Yes. May God be with us as we round up this virtual training session today. Amen. Good morning once again. Welcome to today's session of our pre-conference Oncology Pharmacy Training Workshop. Before we start today's session, I will just do a brief recap of what we had last session. So last session, we had different topics. We started with national chemosafe policy and overview of chemotherapy safety. The presenter started by informing us that Nigeria faces approximately 127,000 new cancer cases and 80,000 deaths annually. She spoke about the safety policy, and she said that the chemosafe policy was launched in Nigeria in 2021, and the aim is to institutionalize chemotherapy safety and establish uniform protocols across treatment centers to protect staff, patients, and of course, the public and the environment. She spoke about the risk profile, and she emphasized that while chemotherapy benefits patients, health workers face risk from exposure without any balancing benefit. She went ahead to mention the exposure points. She said that workers can be exposed during reconstitution, during administration, handling of body fluids, spill management, and waste disposal. We also looked at occupational health and hazardous drug safety. And the presenter that handled the hazardous drug defined hazardous drugs. And she said that these drugs are considered hazardous if they exhibit carcinogenicity, teratogenicity, reproductive toxicity, organ toxicity at low doses or genotoxicity. And she mentioned the examples of hazardous drugs as cisplatin, cyclophosphamide, doxorubicin, and vincristine, among others. And she said that many of these hazardous drugs are classified as category D or X regarding the fetal risk. She also spoke about medical surveillance, that our facilities should implement medical surveillance programs to monitor the health of staff working in hazardous areas. Then another presenter handled technical skills in chemotherapy reconstitution. He mentioned core competencies, and he emphasized that beginners must master aseptic manipulation, accurate dose calculations using bodies of specialized equipment like biosafety cabin system transfer devices, which will be handled during the hands-on training, because we'll have a practical demonstration of how to use closed system transfer devices, and of course how to handle hazardous drugs in your biosafety cabinet. That will be handled properly during the hands-on training. The presenter also spoke about safe handling. And he emphasized on practical techniques away from the body, proper syringe handling, and aerosolization control during withdrawal. He also spoke about quality assurance, adherence to double checking of doses and documentation, how it's very critical active equipment. She started by showing us the hierarchy of controls, and she emphasized that PPE is the last line of defense in the hierarchy of controls and must be used at all times when handling hazardous drugs. She told us that the standard PPE includes chemotherapy-tested gloves, double gloving, disposable gowns, polyethylene coated, N95 respirators, and goggles or face shields. She emphasized that there are restrictions, and she said that standard lab coats and surgical masks are prohibited as they provide inadequate protection against hazardous drugs. The last presenter handled the waste management and spill control. He emphasized on waste segregation, that cytotoxic waste, syringes, needles, contaminated PPE, and patient body fluids must be disposed of in clearly marked, sealed containers. And he spoke about the proper way to dispose hazardous drugs, that issues. That is the preferred method for the full destruction of cytotoxic substances. He concluded the presentation by speaking about spill management, and he emphasized that spills range from few drops to large volumes, and that all staff should have access to spill kits and follow institutional policies for reporting and documentation. Thank you so much. So this is a brief recap of what we had last session. Today we have the team from Abbott Zaria speaking on setting up of oncology pharmacy unit and proper cold chain management. And the team is led by the pioneer chairman of OPAN, our own firm, Ramatu. She will introduce herself and do the preamble, the introduction for the topic. Then the other presenters will follow. So please, the presenters, you introduce yourself before you start your presentation so that our participants will get to know you well. Thank you so much, Fam Ramatu. You can unmute yourself, please. Over to you, ma'am.
Okay, thank you very much. Am I audible enough?
Yes, we can hear you, ma'am.
Okay, good morning, everyone. And well done, Chairman Opan, for all you do for cancer patients. Thank you very much to all the participants that have stayed from the beginning till the end of this pre-conference workshop. I'm very sure you must all have learned a lot. And I just want to say that for oncology pharmacy, you should be committed to a lifelong learning, because the education is continuous, the training is continuous. We all know that new drugs comes in every day, anti-cancer medications. So definitely, what we learned yesterday is not the same thing as what we are going to be learning, is what we are going to be learning today, and it's not what we are going to be using for future purposes. So this, for today, which is the last day, this team will be handling how you are going to set up your oncology pharmacy unit in case anyone want to set up in their different institution. And number two, we are going to be taking one of a very, very important equipment that is necessary, in the reconstitution room when you are doing chemotherapy mixing. But talking about biological safety cabinets and why it is necessary that you should use a BS class 2 cabinet and not a compounding aseptic containment isolators. What is the advantage of one to the other? Or when you have the other one, you can just use it primarily, but the one that is actually necessary is the biological safety cabinet. And then lastly, we are going to be talking about cold chain management and the storage of cytotoxic drugs. We all know that in order to get the outcome that is desired in our cancer patients, you need to store your drugs very well at the required temperature. And if you are not storing those drugs at the required temperature, you know what it means. You are going to be, they will be losing their potencies, they will be losing, and at the end of the day, you are not going to get the efficacy that is desired, in those medications. So storing them, this particular training will teach you how to store, will teach you what you are going to do when you have power outages. This training will teach you when you have temperature excursions, during when you are handling your drugs. And it will teach you what to do at any point in time. So my name is pharmacist Ramatu Masood Alabelewe, an oncology pharmacist, former OPAN chairman. Without taking your time, I will first introduce the next speaker, which is our pharmacist Nafisa Nana Yahuza, who will kickstart this training with the setting up of an oncology pharmacy unit. And she will take number 1 and 2, while pharmacist Umar Mukhtar Damusa of the Kaduna State University will take the cold chain management and storage of cytotoxic drugs. We also have pharmacist Suleiman Aliyu of Ahmadu Bello University Teaching Hospital Oncology Pharmacy Unit with us today. And the 4 of us will be available at the end of the whole lectures to take your questions and answers. So thank you very much. And over to you, pharmacist Nafisa Yahuza. Thank you.
Good morning, everyone. Good morning, ma. Am I audible enough?
Yes, please. We can hear you.
So I'm pharmacist Nafisa Yahuza. Like my Oga stated, I'll be taking you on setting of an oncology pharmacy unit. I want to acknowledge the chairperson for her background of what they did last session. It's really going to make this presentation easy because most of the things I'll be discussing have been discussed during the last presentation. So, sorry. So setting up an oncology pharmacy, and the objectives of the presentation will cover, at the end of the session, participants will be able to understand the key components of an oncology pharmacy unit, to identify infrastructure requirements in line with the United States Pharmacopoeia standards, to also identify necessary equipment and safety protocols for the safe cytotoxic handling, which you have already discussed, and then to outline staffing, training requirements, and operational workflow. By way of introduction, we all know what oncology pharmacy is, as being a
Please, can we mute ourselves?
Sorry, the slide is gone, right?
But we can see the slide, Nafisa.
Okay, sorry, I can't. I closed it from my own end.
Wow. The officer or Umar Damusa, can you please mute everybody so that we can? The noise is interfering.
Hello, good morning. The chairperson, can you make me the host, co-host, so that I can be able to
I think
mute
I've
people?
made you. Damusa, you are a co-host already.
Okay. Let me try see if I can mute. Please, participants, those of you that your speaker is on, you can help us mute. It's distracting the presenter. Thank you.
Okay, sorry for that. So as we all know, oncology pharmacy is a specialized unit dedicated to cater for cancer patients. Historically, all medicines, including cytotoxic agents, were dispensed from a single hospital pharmacy unit. And before now, we all know in the olden days when we have cancer patient, I can remember during my internship period, cancer patient will come to oncology pharmacy where all patients are being seen. So at that time, it's tend to delay them because we try to even dodge their prescription because they come with a bulky prescription and you need to find out the availability of the medication because sometimes those expensive drugs like Zeluda are not being stored in the dispensary. You have to confirm from the store if it's available before you now go ahead and cost for the patient. So that was the practice then. So why do you need to separate cytotoxic agent? Because of the name cytotoxic, they are toxic. So you need to segregate them to protect other products that are being stored together. You also protect the patient, the staff, and then the general pharmacy environment from hazardous drug exposure. Like you've already taken that these drugs, there are a lot of means of exposure to them. So you can have droplets, spills, inhalation, and so many routes that you can be exposed to. So it's very necessary that we separate cytotoxic agent from general medication. So why do you need a specialized unit? Because there are growing number of cancer burden, increasing complexity of multiple agents, and then chemotherapy protocols demand that dedicated expertise and infrastructures be put in place before cytotoxic agents are being handled or being dispensed to a patient. And the goal is to have a centralized preparation to enhance safety, reduce medication errors, because like I stated back then, they just come in, we just dispense, we don't know what happened after the dispensing. If the patient reacts to the medication, if there is any side effects, we are not aware. But once you have your centralized unit for cytotoxic agent, when your patient comes there, you dispense, you reconstitute, they administer it there, anything that happens, you follow up your patient is very important and ensure appropriate drug handling and patient monitoring. And the scope is to cover for inpatient and outpatient chemotherapy preparation, clinical monitoring, like I stated, and then structured patient education and counseling, which is very key. So, like I stated, brief history of an evolution of oncology pharmacy in Nigeria. Like I stated, during the early periods, we all know that we didn't have anything like oncology pharmacy. All drugs were mixed up together, they were dispensed with other cytotoxic agent. So, cytotoxic drugs prepared in general pharmacy dispensaries, which containment, no dedicated oncology pharmacy infrastructure. So in the early 2011, there was training by Roche and Sanofi to about six pharmacists from different teaching hospitals. And then these teaching hospitals begin to establish their own dedicated oncology wards, and chemotherapy preparation becomes more pharmacist affair at federal tertiary centers. And then as the year passed by, there was growing awareness of United States pharmacopoeia standards and other international standards. And then I remember in my facility around 2018, we purchased our first biosafety class 2 BSc in our own facility, and other major institutions were all installed within that same period. Before then, we used to have a kind of reconstitution with just PPEs. We didn't have a safety cabinet. Even the PPEs were just goggles, gloves, and were not fully kitted like now. So because of the growing awareness, pharmacists were becoming from 6, they were retraining of others within their own facility, like a kind of step down training. So pharmacists felt there was need to have a professional body, and OPAN was established around 2019. And after that, professional framework for oncology pharmacy practice begins to develop. Training of programs for more oncology pharmacists was initiated. And from that time till now, there is an increasing adoption of standard operating procedures, chemo safe policy, like you had, it was launched in 2021, and structured training, national advocacy for dedicated oncology pharmacy unit across all treatment centers. This is where we are. So in setting up an oncology pharmacy unit, there are some core components or key elements that you need to have in place to have a functional oncology pharmacy unit. One, you need to have the infrastructure in place, which will include the clean rooms, sterile compounding areas, then the staffing, which is very important, specialized oncology pharmacists who have had training and retraining in that aspect. So also trained pharmacy technicians, you need to have guidelines, safety and regulatory protocols in compliance with the standard USP for handling and compounding of sterile products. And then, of course, technology, as we are now, there is an increasing advanced technology. You need to have electronic ordering to minimize some medication errors, barcoding and scanning for verification, and then the use of closed system transfer devices. So now, the key component of an oncology pharmacy unit is to have the infrastructure and then the facility design. The location of an oncology pharmacy should be in such a way that it is central within the hospital, in a low traffic area of the hospital, away from patient waiting areas, canteens, and break rooms, to minimize contamination and risks. Because like we keep mentioning, cytotoxic, we know what they can do. We know they are carcinogenic, they are mutagenic, teratogenic, so we will not want to expose anybody to such agent. Then the design should be in such a way that you have a negative pressure buffer room with a dedicated anteroom. That's a preparation room. That's an anteroom where you do your preparation, you where your PPEs before you get to the clean room, where the main reconstitution take place, and it has to be in compliance with the United States Pharmacopoeia Structures requirement. So clean room is necessary to protect the product from contamination, which will be too hazardous to produce in an open environment. Then the air handling should be, you should have a dedicated non-recirculating exhaust system for hazardous drugs handling, 100% exhaust air from buffer room to atmosphere. Then heating, ventilation, and air cooling should be around minimum of 30 air changes per hour of supply. High efficiency particulate air filter supply, continuous pressure monitoring with alarming. Now, the key functional areas in an oncology pharmacy unit will include the hazardous buffer room, which should be in accordance with ISO class 7, which is an international cleanliness standard that limits concentration of airborne particles in the place. And the key requirement should be that it should have a negative pressure 30 plus air exchange per hour, and then high efficiency particulate air filtration. The walls should be coated with epoxy coated walls and the floor. Then the anteroom, which is the preparation area, should also be in the same standard of ISO class 7, which is where the area where you're going to be having your hand washing station, gabbing area, material decontamination before entry into the main buffer room. Cytotoxic drug storage should have a controlled negative pressure, and it should be segregated, labeled storage area separate from general pharmacy stock. Like we mentioned from the beginning, before now, all drugs were in the same area. So you need to have separate, like a kind of oncology store where your cytotoxic are stored separate from other normal drugs. Then you should have a patient counseling area. That's the general pharmacy area. Like in my own place, we have a general pharmacy area where we do the costing of the medication, patient counseling, and we have a separate reconstitution area where preparation of such hazardous drug is being handled. So it should be private, confidential space for structured patient education and medication counseling. Then the environmental control should be in accordance with standard, also high efficiency particulate air filtration throughout, and then all part 2 epoxy paint on all surfaces, continuous environmental monitoring for contamination. The United States Pharmacopoeia is a regulatory standard aimed at minimizing the exposure to hazardous drugs in healthcare settings. They outline best practices for handling, storing, and disposing of hazardous drugs to ensure what workers, patient safety, as well as the environmental exposure. So talking about the essential equipment that you need to have in place. During the introductory aspect, the chairperson mentioned primary engineering control, how you protect yourself from cytotoxic exposure or hazardous drugs. There are about 5 methods in which these controls can be done. And the best is the elimination, then followed by substitution, and then engineering control, which is the third most best method to protect yourself. And then we also have the administrative controls. And then finally, she mentioned the PPEs, which are the least method of engineering control. Controlling exposure to occupational hazard is the key fundamental method of protecting the workers. So primary engineering control is very key. And that is why class 2 biological safety cabinet or compounding aseptic containment isolators are very core containment device for cytotoxic reconstruction. Now, the pass-through chambers should have a high efficiency filter particulate air that will pass through for transferring materials between the anteroom and the buffer room without disrupting the pressure differentials in the room. And then the dedicated storage should be separate, clearly labeled pharmaceutical grade refrigerators, ambient storage cabinet for anti-neoplastic products with continuous temperature monitoring. We are going to be taking the last aspect of this presentation where you'll be seeing the importance of continuous temperature monitoring because of the peculiarity of cytotoxic agent. So waste management, you should also have a dedicated cytotoxic waste containers, yellow coded, punctured resistant, and access to high temperature incineration facilities because that's the best way to dispose cytotoxic agent, incineration at a very high temperature. So this is a pictorial presentation of our own oncology pharmacy reconstitution room. You can see the biological safety cabinet, and the fridge is beside the biosafety cabinet. We have the door to the preparation room where you are going to be fully kitted before you get into the cytotoxic preparation room, because you need to have what aseptic product at the end of the preparation. So this is a pharmacist trying to prepare the biosafety cabinet for his reconstitution. So this is reconstitution process ongoing. So in ensuring that the facility design, the airflow requirements should maintain a negative pressure, like I mentioned, in compounding areas to prevent the spread of contamination. You should also segregate work area into ante room and a buffer room, that's preparation room and clean room. You should also have HEPA filtered pass-through for material transfer, and then minimum of ceiling height of 3 meters for proper ventilation. Now, the next component is staffing and competency. Why do you need a specialized pharmacist? We are all pharmacists and we want to believe we all went to the same pharmacy school, but in handling cytotoxic agent, you need to have a training and retraining. Like my Oga mentioned, so many drugs are evolving. What you know yesterday might not be what is trending today. So it's very key that the pharmacists and pharmacy technicians are very trained in oncology pharmacy practice. And also, you could have technicians, cleaners, and porters that will also play one or two roles in the reconstitution room, because you alone, you are already mixing the cytotoxic agent, so you may need one or two persons assistance. Then the cleaners, in case if there is spill, they will assist you in one or two things on how you go about cleaning the area. Of course, all these cleaners and porters need to be trained also. So training, like I keep mentioning, rigorous and documented training in aseptic techniques, hazardous drug handling. You have done this before. Spill management, closed system drug transfer devices are very emergency procedures. So you need to have a regular training and retraining of your staff on hazardous drugs handling, storage, compounding, as well as waste disposals. They are very key in oncology pharmacy practice. Then you also need to have competency assessment, a kind of annual formal assessment covering sterile techniques, CTS usage, spill response, PPE donning, with result documented. This is to ensure that the staff are still active in that field, and then aseptic technique and spill management are adhered to. Then, like she also mentioned in your last presentation, there is need for medical surveillance, because like we keep mentioning, cytotoxic agents are carcinogenic, mutagenic, teratogenic. So there is need to have a structured operational health monitoring program for all staff regularly exposed to cytotoxic agent, because over time you don't know what they have inhaled, because there are so many routes in which you can be exposed to this cytotoxic agent. So this is very key for pharmacists that are handling cytotoxic agent. Like I mentioned, United States Pharmacopoeia safety protocols is a mandatory standard, and compliance is not optional for any facility handling these drugs. So it's very key. Is a guideline that states how you handle this cytotoxic agent, how you do all these procedures, how you do a personal protective equipment. All these are necessary. So one of the major safety protocols is ensure that you are fully kitted with what? Double chemotherapy grade gloves, not single gloves, not all kind of gloves, closed front protective gown, N95 respirators, face protection like Google's. They are all required during hazardous drugs handling and disposal activities. Spill kits are very key. They should be readily available and accessible in all areas where hazardous drugs are being handled. And staff must be trained in their usage before commencing work in case of any accidental emergency spills. Like I mentioned, medical surveillance, which is also very key. Then hazard communication. This is also very key. Areas where such toxic agents are being handled are not supposed to be free entry for all. They're supposed to have caution signage, clearly labeled with standard cytotoxic hazard symbols for staff, so that anybody that doesn't have business within that area should not even come to that area to risk his health. Even though it's not just the one-day exposure that may lead to, we are talking about long-term exposure and then the amount that you are being exposed. So this is also very key in chemotherapy reconstitution room. So this is a pharmacist, fully kitted, about to kickstart his for cost-saving initiative, medication optimization, like we have the dose binding, dose rounding, vial sharing protocols, which is very common in reconstruction room, waste reduction, just-in-time preparation. You have to ensure that the patient is on ground, and then all the laboratory values are okay, and the patient is fit to take that chemotherapy before you go ahead and prepare it. Stability data to extend prepared dose shelf life, then in case you have some situations whereby you have already prepared the drug and then one or two things happen that the patient cannot use the medication. The use of closed system transfer devices to reduce staff exposure and associated occupational health costs, even though I know that most facilities are not yet there, but we're hoping to be there. And it's a very key, important area in oncology pharmacy practice. In the advanced world, they are developed more than this. Some countries, you see a kind of robotic reconstruction by some countries. So not even to talk of closed transfer system devices. So, but we'll get there one day. So what are the challenges and the opportunities that you're likely going to encounter in setting up an oncology pharmacy unit? Major challenges that you encounter is shortage of trained oncology pharmacists and technicians in Nigeria. The space constraint, most hospitals are not designed for dedicated cytotoxic pharmacy suites. So they will just have because the building is already there, it's not as if they want to start building a fresh oncology pharmacy unit for you. So they may just give you one small room, one small space for you to just start. So this is a challenge for most facilities. And then under funding, oncology pharmacy infrastructures often are deprioritized in hospital capital budgets. And then inconsistent power supply compromises the integrity of the equipment and then the cold chain. So it's important that you have a backup, like now we have the solar inverters in case of power outage. So what are the opportunities for the growth of oncology pharmacy? We have precision medicines now on board, like the pharmacogenomics, guided chemotherapy dosing becoming more accessible. And then the immunotherapies are expanding now, expanding checkpoint inhibitors to inhibitor use creates a new oncology pharmacy roles. And then there is upon advocacy, national standard and training certification pathways in development to ensure that we have more trained oncology pharmacists in Nigeria. And then the technology where we have telehealth, electronic prescribing, and AI dose checking. I also mentioned in some countries, they are not even using humans for reconstruction. So these are some opportunities for growth in area of oncology pharmacy. So in conclusion, in all that we have said, there is one thing we are trying to ensure, which is safety. Safety of the what? The personnel, the environment, as well as the patient products you are preparing. So it's very important in setting an oncology pharmacy, you invest in patient and staff safety. Then to secure a support, you obtain executive and funding body commitment before commencing design or procurement. To build a standard, you need to design and construct a pharmacy space in accordance with the United States Pharmacopoeia standard and applicable local standard. Regulatory compliance with hazardous drugs handling standard is non-negotiable. You train and assess, develop comprehensive standard operating procedures, train and retrain your staff, conduct documented competency assessment, improve continuously. Quality assurance, continuous professional development are the foundation of long-term safety. Call to action. Start planning your oncology pharmacy unit today. And there are some key takeaways from this presentation, which will include prioritize safety, like I keep mentioning from beginning to the end of this presentation. In all we are doing, we are trying to ensure safety of the staff, the environment, and the patient also. Neither of this can be compromised. Then cost versus long-term benefit. The capital cost of setting up a compliant oncology pharmacy unit is significant, but it is substantially less than the long-term cost of staff illness, litigation, medication errors, and regulatory sanctions. Closed system transfer devices are critical technology for reducing cytotoxic contamination at the point of reconstitution and administration. Their adoption should be a priority as well. These are some of the references that were used and for any further reading during the presentation. So this is the end of the first section of the presentation, setting up an oncology pharmacy unit, in which we have 4 core elements of setting up oncology pharmacy units. Infrastructure, you need to have the facility on ground, you need to have the staff, you need to have to comply with safety and regulatory standards, and then finally you need to have some advanced technologies that will enhance professionalism and then enhance patient safety as well. So thank you. I don't know, am I audible enough? I've been talking to myself since.
No, you are very audible.
Yeah.
You are very, very
You are
audible.
very audible. Loud and clear.
So the next section of the presentation is we're going to be looking at biological safety cabinet and then the compounding aseptic containment isolators, which are the key equipments that are being used in reconstitution of cytotoxic agent. And by the end of this session, participants will be able to differentiate the mechanical design of class 2 BSc and CACIs, to evaluate airflow patterns and filtration requirements for hazardous drugs containment, and also identify specific facility clean room requirement for each equipment type, even though we have already discussed this in the previous section, and then select appropriate primary engineering control based on the volume of medications you are being reconstituting, and then the budget as well as the safety goals. So why do we need a containment? Like we mentioned before now, we used to reconstitute by one side of the pharmacy in an open environment. We just try to use our gloves and then our goggle. So like we keep mentioning, hazardous drugs are carcinogenic, mutagenic, teratogenic, posing a serious operational risk without adequate engineering control. And I mentioned that there's some key controls, starting from elimination.
This meeting is being recorded.
To PPE usage. So, but the best thing is engineering control, which is the third tier of the stages of control. So the need for containment is to maintain sterility for the reconstituted preparation through validated aseptic techniques and clean work environment, and also to protect the personnel and the environment, preventing exposure of the operator to cytotoxic aerosols, vapors, spills, and droplets, which we have mentioned that there are various ways that you yourself, you don't know, you have been exposed to this medication over time. And then preventing environmental contamination to make our environment safe for everyone. So BS class 2 is an open front ventilated cabinet providing personnel, product, and end product protection through vertical laminar airflow and a protective air curtain at the front opening. Like you have seen in the diagram, the class 2 BSc has an opening, like a door, a glass door, which you control. You either close completely if it's not in use, or you just open it halfway when you are working. So the aim is personnel protection. So it is designed in such a way that it should have a laminar airflow. Laminar airflow with high efficiency filter air descending vertically over the work zone to prevent cross-contamination of the product. This HEPA-filtered sterile air flows downward over the work surface in a unidirectional, and that's the laminar airflow we are talking about, pattern, ensuring product safety, right? Then there is an air curtain at the front opening of, for personnel protection, an air curtain at the front opening of the door pulls the room air inwards inside the cabinet, preventing hazardous aerosols or drugs particles from escaping towards the operator. So during your work schedule, there is a mechanism that pulls the air inward to prevent it being pulled backward, so that you are being exposed to that bad air. So high velocity inward airflow at the front opening prevents the room air from entering and traps internal aerosols. Then the environment control. The environment control is carried out in such a way that all air exhaust from the cabinet passes through the HEPA filter to remove contaminants before they are being released into the environment. And we have different types of class 2 biosafety cabinets. We are talking of the class 2, which is the more ideal. So, but we have the class 1, class 2, class 3. And there are different subtypes like the A2, B2, which is the recommended, because it has 100% total exhaust. There is no air recirculation, and it's recommended for volatile chemotherapeutic agents. While the A2 is around 7% air recirculated internally, and the 30% is being exhausted. And this requires a hard cut canopy connection for volatile agents. So in essence, class 2 biological safety cabinets, they draw the air in the room at a minimum of around 100 feet per minute, which forms a protective air curtain that prevents aerosols from escaping. And this air is being drawn along with internal work air into the plenum of the cabinet, where roughly 70% is being recirculated, like I mentioned earlier, through the HEPA filters as laminar downflow for product protection, and 30% is being exhausted through a separate HEPA filtration. So that is how the BS2 works in essence. So this is a typical diagrammatic picture of the biological safety cabinet. And now, the compounding aseptic containment isolators. Hello? Can you mute yourself, please? So is a closed, ventilated, pressure monitored enclosure, providing a physical protection between the operator and the hazardous drug. The work is being performed through an integrated gloves. When you see the picture, you understand the statement I'm trying to make. And it has a physical barrier that is usually made of type of stainless steel with a viewing window that creates a leak-tight environment. So the physical barrier, all manipulations performed through the integrated neoprene hyperlung gloves. That means there is no open front door that will expose the pharmacist. So there is no risk of airflow disruption or exposure during preparation. So, and then the negative pressure, the environment is secured. The work zone is maintained at a lower pressure relative to the room temperature. So this ensures that any breach in the system draws air inwards, preventing hazardous vapors or particles from escaping. So that's how it works. Maybe when you have the physical session, though we are not going to be seeing the isolators, but we are going to be seeing the biosafety cabinets. You have more understanding of what I'm trying to say. So the transport ports or airlock allows supply transfer without breaking the main chamber sterility or pressure envelope. So it means that the chambers are interchanged and it allows for the safe transfer of materials in and out of the main work zone. Well, let me just show you the so that you'll be able to understand how the isolators are. You can see the globes where you are going to be working with. So in and out of the main work zone while maintaining the pressure difference. And then the exhaust work in such a way that both supply and exhaust air pass through the HEPA filters too. And then for volatile hazardous drugs, the isolators must be hard ducted to a dedicated building, which is an exhaust system to remove chemical vapors that HEPA filters cannot remove or cannot trap during the procedure. So that is how the exhaust system works. It must be externally vented through the HEPA filters to ensure that toxic vapors are removed from the building entirely. So this is a diagram of how the isolators look like. This is a easy clean work zone. These are the gloves. These are the disposable system attached to the machine. And then this is sliding work tray that is being removable. This is where the airlock pass chamber is. So now, head-to-head comparison. What are the differences between these two equipments, or what are the advantage of one over the other? So for the access, having access to the, like when you look at the diagram, you can see that the BS2 has a open front door. So this provide a protective air curtain. So it relies on high velocity air curtain to maintain containment, while the other one is a closed system. There is no any opening aside from those gloves. So personnel access materials only through the sealed gloves. That's you use the gloves, you use your hand inside to access whatever you're doing inside the equipment. So what level of protection do
The
they
recording
all have?
has stopped.
They all have a very high level of protection, but with the isolators, they have the highest physical barrier based on the air
This meeting is being recorded.
which prevents the escape even if the power is lost. But for the class 2 BSC, there is rapid movement, or if there is air turbulence, they can lead to they can break the air containment. You understand? So in terms of ergonomicity, the BSC class 2 has good mobility and working range, easy movement and easy to set up, while the other one, there is restricted movement because of the presence of the gloves, and materials must pass through the interlocked airlocks. So the airflow, this one is vertical laminar, that's downflow, while this one is unidirectional. The pressure is, they are all negative pressure relative to the room. So, but the The isolators have a stronger negative pressure through the enclosure. So cleaning the equipment is easier to clean the class 2 PSC because of how the opening it has, while this one is more complex because of the presence of those gloves. You have to, everything you're doing, it has to be within those openings. And then the requirements for the rooms, like we mentioned, negative, but it has to be according to ISO class 7 standard buffer room, negative room as well. But then the isolators need to be in a classified segregated compounding area that is acceptable if isolators meet leak test standard. There's some leak test standard that need to be carried out. So they need to be in a classified segregated compounding area. So you can see that it's easier to mount the ESC2 compared to the isolators. So this is just a kind of repetition of installation requirement. So setting up an oncology reconstruction room requires more than just the equipment. There's some standard that you need to meet of the room also before you go ahead. You don't just go and install in any open room. There has to be some standard guidelines that we keep mentioning, the ISO class 7, which is an international cleanliness standard that limits concentration of airborne particles. So it has to meet that criteria before you mount any BSC2 in that particular place. So it must be sited in an ISO class 7 buffer room, and it must be maintained at a negative pressure relative to the adjacent areas. It requires a separate ISO class 7 anteroom for gowning. We keep mentioning the anteroom and the buffer room. That's the preparation room where you put your gowns, your PPEs, you do whatever you want to do before you get into the buffer room, which is expected to be an aseptic area. So the sensitive to room air turbulence, do not place near windows or doors and then AC vents because air turbulence can easily affect it. Then the exhaust must be hard ducted to atmosphere, no recirculation to room. No recirculation to the room heating, ventilation, and air conditioning. While for the isolators, it needs to meet the United States Pharmacopoeia standard of classified segregated compounding area. If the isolators meet specific leak test standard, and then preferred for facilities where a full ISO class 7 clean room suite is not feasible, where you cannot have access to the requirement of the ISO class 7 buffer room. So it may be by the time you do further readings, you need to understand what are these major requirements that a room should have before you can install a biosafety cabinet. And then still requires a controlled temperature regulated negative pressure room. Like I mentioned in the differences and similarities, the negative pressure is relative to the room in BSC2, but in the isolators, it requires a stronger negative pressure room, and the exhaust must be externally vented through HEPA filtration as well. So after installation of your biosafety cabinet, there is need for maintenance and certification. So it must be certified upon installation, and then every 6 months, there should be a kind of monitoring after any relocation or significant repair by a accredited certifier. Then you also need to carry out some integrity testing of your filters. You need to do a leak test testing using which is a test that ensures filters has no any damage. And most of the time they use DOP, PAO aerosols, which are polyalpha olefin, and then the DOP is diacetyl butylate aerosol challenge test. It is mandatory at each certification cycle to confirm filter integrity and absence of leak. Then PPE requirement, full oncology rated PPEs like the chemotherapy gown, double gloves, face protection like the goggles is required even when working with the isolators according to standard guidelines. And then the daily decontamination is very necessary since we keep mentioning that we need to have an aseptic environment in as much as we want to ensure that we need to have a daily decontamination. You can clean with germicidal detergent, or you can use 70% isopropyl alcohol. This neutralizes hazardous drugs residues periodically with sodium hypochlorite and then followed by sodium thiosulfate. So you may need to have trained personnel or um, people that are involved in area of cleaning, like the microbiologist, which handles a lot of this things. So they have a standard of how they do their daily decontamination. So you can liaise with some of them and they'll give you the materials if you have any in your facility for daily decontamination of your biosafety cabinet before you do any reconstitution. So now, how do you select the right tool? Is it the BSC tool or is it the isolators? We all know that they are all okay, they all have their advantage or their disadvantage, and they are all going to do the same work that we are trying to have protection of ourselves and the product as well as the environment. They all do that. But then how do you decide when you want to have one for your facility? You need to look at your budget. The BSC have lower upfront equipment costs, but higher clean room construction costs, while the isolators reduce room requirements, but carry higher capital expenses. That means the room for installation of the isolators, the cost implication might not be as high as that of the BSC2, but then the equipment is more expensive than the BSC2. And then power stability. The isolators are sensitive to pressure drops during power outage, so you need a reliable USB or generator backup and a critical consideration given Nigerian power infrastructure. So you need to consider all that. While the BSC2, once there is no light, I think you have to, maybe if you have a standard standby generator, or you have to wait for light to come back. And then the volume of medications you are preparing. Okay, your center, is it a teaching hospital? How many patients do you see per day? How many medication do you reconstitute? So high volume centers often favors BSC2 because of the speed of the work. When you want to, you can reconstitute sharp, and then, but with the isolators, the operation we said is a bit complex. You have to even be super trained on that before you. So, and they may limit through put due to restricted movement through the globe. So it's like the BSC is more advantageous than this one when it comes to high volume of medication. Staff training. So also the isolators require specialized training for glove box dexterity and the glove integrity checks. Both technologies require validated aseptic techniques, but with the PSC2, once the training might not be as complex as with that of the isolators. So the bottom line is that the best system is the one that is correctly installed, maintained, certified, and used with proper technique. So in conclusion, both technologies are effective when used correctly. The key differentiator is the operator's technique and rigor of equipment maintenance. Safety is a system. The primary engineering control is only as good as the aseptic technique of the pharmacist and the integrity of the HEPA filters. And then the goal for Nigerian oncology pharmacy practitioners is to ensure that there is zero occupational exposure, which should be achieved through correct selection, installation, and certification, and good practice of the pharmacist. Thank you. This is the end of my presentation. I'll be calling on the co-presenter to take you through the cold chain management and storage of cytotoxic drugs. Thank you. Pamdon Musa.
Thank you so much, Pam Nefisa. That was a very detailed presentation. Thank you. I'm sure that facilities that are yet to commence to set up their oncology pharmacy units, everything is becoming clearer now because people do ask me, should we do this? Should we do that? You've seen what she started from where they started and then where they are now, you know. So please, I'm sure everything is clear now what you need to do. The essence of this training is to equip us with all the information we need to be able to do the right thing. So the slides will be made available for you so you can always go through it and be able to understand exactly what you need to do because you are handling hazardous drugs. So you can't just go and set up and start doing what you're not sure of. Thank you so much, from Nefisa. From Madam Mutasa, are you ready for us? Yes, sir. You can introduce yourself and continue.
Yes. Hello, good morning, all. Please, Pam Nefisa, you can help me continue to present from your own side. I will get through with the presentation. Thank you. I hope, am I audible enough?
Yes, you are. Yes, you are, sir.
Okay, thank you very much.
Sorry, Fam. Sorry.
Yes.
I'll do that.
No problem. Okay, is it the introduction or what? So yeah, no problem. I will continue now.
Okay.
Yeah.
Oh, sorry.
No, I would like to appreciate OPAN and WACP for organizing this wonderful workshops training. Ours that we will take now is cold chain management and storage of cytotoxic drugs. And if you can see from the first slide, there are some symbols there. The first one was C in a triangle, written cytotoxic. So that is like the cytotoxic level, which we'll be discussing in due course of our presentation. So we can go to the next slide. So the learning outcomes of this research, of this presentation, yeah. By the end of this lecture or workshop, the participant shall be able to first explain the principles of cold chain management as applied to cytotoxic drugs. They should also be able to identify and categorize cytotoxic agents according to their specific storage temperature requirements. They should also be able to describe the infrastructure and equipment standards required for compliant cytotoxic drug storage, implement standard operating procedures for receipt, storage, and monitoring of cytotoxic agents, recognize and also document cold chain excursions and storage deviations, and apply relevant regulatory and safety frameworks governing cytotoxic drug exposure, storage. So that is our objectives or learning outcomes for today's lecture. Now we'll look at the introduction of and also the rationale for cold storage and different storage conditions for hazardous drugs, especially cytotoxic agents. As you all know, cytotoxic drugs like Nafisa has explained in her earlier statement, they are one of the most pharmacologically complex and hazardous agents dispensed by clinical pharmacists. Please, next slide. So their narrow therapeutic indices make product integrity non-negotiable. Even minor deviations from recommended storage conditions can render a preparation ineffective or generate toxic degradation products. So the cold chain encompasses the entire temperature control supply chain from manufacturer to the patient's bedside, and its integrity directly impacts patient safety and treatment outcomes. As you can see, the key principle is like a broken cold chain has to be a cold chain has to be maintained, because a broken cold chain does not always produce visible changes in appearance or odor. Sometimes you can see visible changes, but not all time. And the only assurance of product integrity is a documented, uninterrupted chain of custody under validated temperature conditions. So why cold chain matters in oncology? One is like cytotoxic. As you all know, cytotoxic drugs have narrow therapeutic windows. There are some, so if there is excursion of temperature, cold chain is not achieved, subpotent doses reduces efficacy, and where super potent doses can increase toxicity. Degradation products of some agents like phosphomide, platinum compounds, sometimes some of them are nephrotoxic or neurotoxic. So if it's allowed to be degraded, which not maintaining cold chain principle will cause degradation and degradation products can cause these side effects or problems. So many biologics and antibody drug conjugates, they are protein-based and irreversibly denatured by heat or prostocyclin. Prostocyclin is one, that compound or the product is freeze-dry, that is freeze, and then, it then melts. Freeze-melt, that cycling will also causes irreversible denaturing of the proteins, and then hence rendering it not effective. So regulatory non-compliance with storage standards can result in product recall. So when there is non-compliance, you hear of product recalled, pharmacy license revocation especially, and also medical legal liability, because now people know their rights, and when they know something was done intentionally, or they can easily carry it to court, and it is an issue for the oncology pharmacists. So cost implications, cytotoxic agents, you see, they are among the most expensive drugs in clinical use. Or like we have the tuximab, Herceptin, and the rest, those biologics. An excursion event can result in write-offs of tens of thousands of dollars or nairas, for one single excursion or temperature excursions. So we will move to the next slide, where we'll see classification of storage temperature ranges. This classification is according to International Pharmacopoeia Standard, where it defines temperature categories. Pharmacists must be familiar with these definitions and verify them against each product summary of product characteristics. That is, sometimes you find them online, while most of the times it's found in the product insert, the label insert, that one big paper like this that contains everything. So you should, as an oncology pharmacy, those types of papers are very important. You should be, updating yourselves regularly with what was always all that is in those summary of product characteristics. So the categories are, we have deep freeze, We also have refrigerated, we have cool room temperature, and also with the light sensitive drugs with their temperature ranges, pharmacopoeial terms that are used, like if it is cool, they say cool storage, and room temperature, so at room temperature, while those that are protected from light, that are light sensitive, should be protected from light. There are some examples of some drugs there, especially protection from light, which is very important for us to know. Carbazine, methotrexate, like doxorubicin and fluorouracil. We can go to the next slide. But one thing you should know is you need, like I said, always consult the current product summary product characteristics or package inserts for storage conditions, reconstituted or diluted preparations. Most at times, they differ significantly from those of the intact vial. So such specifications are, written clearly in those of summary product characteristics. So there are some special considerations, especially for reconstituted and diluted preparations. When you have the intact vial, the storage conditions, most of the times, like I did mention, it differs from when it is diluted or reconstituted. And like for instance, oxaliplatin, once reconstituted, many agents have a shortened stability window. Like we say gemcitabine, stable at 24 hours at room temperature, and paclitaxel in diethyl. This is a type of bags, that are not containing diethyl hexyl phthalate, which is a compound that is usually incorporated in polyvinyl chloride bags for the flexibility. So most, so paclitaxel and docetaxel, they are products that has surfactant, and when in these types of bags, they tend to extract the DEHP into it, and then it can cause toxicity. So in those pre-bags, that is why paclitaxel is usually stored in these types of bags when reconstituted. So 27 hours at 25 degrees Celsius. Reconstituted oxaliplatin must not be refrigerated, and cold temperature when you reconstitute it causes crystallization and loss of potency. We have seen a lot of this while I was practicing as an oncology pharmacist, and it's one of the that time one of the major problem we experienced. I didn't know that this product should not be refrigerated. Their storage conditions are different when they are reconstituted. So for carboplatin and cisplatin, IV bags should not be refrigerated also because post-dilution due to precipitation risk. So these are some of some special considerations that we should know that they are available. For instance, the stability of the product after reconstitution, and also the stability or the storage condition of the product after reconstitution and reconstitution. So we will look at the infrastructure and equipment requirements in our next slide. Appropriate physical infrastructure is foundational and to maintain cold chain compliance. Pharmacy managers or oncology lead pharmacists must ensure that equipment meets the following minimum standards. So for refrigerators, they must be pharmaceutical grade only. Domestic units are not acceptable for cytotoxic storage. Pharmaceutical refrigerators usually I maintain uniform temperature between 2 to 8 degrees Celsius with validated temperature mapping across all shelves. Units must be equipped with continuous electronic temperature monitoring data logging capability. Visual or audible alarms must be activated when temperature falls outside the range. And there should also be a backup power USPO generator, so that the cold, chain should be maintained in our refrigerators. There is also ambient storage that is dedicated, lockable, ventilated, and temperature control. Shelves should be maintained between 15 to 25 degrees Celsius, and air conditioning units must be validated and maintained. And all cytotoxic, as pharmacist and Nafisa has been, expatiating, they must be segregated from non-cytotoxic medicines. So even, in the stores, in the fridges, they should be, separated from other non-cytotoxic drugs. So labeling and access, you have to clearly label cytotoxic or hazard symbols displayed prominently. So those types of the triangle that I show you in the first slide, they have to be, pasted on the fridges and also on some of the shelves or areas where cytotoxic are stored in the store. And also access should be restricted, as you mentioned, to trained and unauthorized personnel. So next slide, please. So there is also, temperature monitoring system. A robust monitoring system must include continuous data loggers. So you should have electronic, usually electronic, with at minimum of 15 minutes recording interval. There should be, remote alarming capability when there is problem in, the temperature, because you are monitoring the temperature. So alarm system should be there. Audible on-site alarm, either that is the minimum standard, but in some best practices, you have a remote or SMS email alert to on-call staffs, so that they can easily, in case of probably power outages or maybe another technical issue, maybe the fridges are not working well, or there is deviations from the range temperature range. So alarms should be, or SMS message should be sent to the staff on call or to the lead of oncology pharmacy. You have to calibrate those best practice is biannual with full temperature mapping. There is data retention for your calibrations. It should be at least 2 years minimum. For best practice, you should keep them for 5 years or for a lifespan of the institution. And backup power, at least you should have UPS for alarm continuity. While best practices, you can have full generator backup for all refrigerators unit. So we will look at the SOPs now. As it is very important when receiving goods, how the SOPs for receiving and also inspection of cytotoxics, as we are to also look at the storage conditions of cytotoxic agents. So upon receipt, you have to inspect all cytotoxic deliveries immediately upon arrival and do not leave unattended. So we know that sometimes in our stores we have, multiple deliveries, multiple receipts, but special priority should be given to cytotoxic agents, because leaving them unattended, may cause deviations from temperature ranges if left unattended for a long period. So, receipt of cytotoxic agents should be as, as brief as possible, but put in mind that, all the requirements, the SOPs have been followed, well. So you check the packaging integrity immediately if there is damage either, or you see signs of moisture or freezing for products that are not allowed to be freezed, or light exposure, especially some of the products that are not supposed to be exposed to light, that are light sensitive, like we said, the carbazine in our earlier classification. And you also need to verify temperature indicators. So for oncology drugs and those, temperature regulated products, you have to look at the data loggers or enclosing the shipment, document readings. So you have to make sure that there is no time, in handling of such chemotherapeutic agents went beyond, the acceptable limits of temperature range. Even when it runs out of that, it's not beyond the limits that it should be allowed to be out of that temperature range. You have to cross-reference the delivery note. This is very, very common in all our, receipts of orders, to check whether if the product is a product that was, requested for, the strength, the quantity, the batch and expiry. So this is very common with all other products, not only oncology products, but it should be very, critical when it comes to oncology pharmacy. You have to quarantine suspected stock immediately. You label them do not use, or you label under review, and then you notify.
The recording has stopped.
Notify your pharmacy manager. You transfer refrigerated products immediately to the designated pharmaceutical refrigerator for storage within 15 minutes. So that is why we say you should not leave them on deck unattended. It has to be attended, briefly. Once it is, retrieved, it has to be attended to. And then complete the incoming goods record for your stores. Or maybe if you have the pharmacy information center, you fill in the informations. So this is like for receipt and incoming of goods inspection.
This meeting is being recorded.
The next step, please, the next slide. So also for inventory management and dispensing. For inventory management, is very important. You apply, that is for the storage, the SOPs. You have to apply the people that is first in, first out rigorously, because of, our first presenter emphasizes that these are drugs that are very expensive. And if you have to take sure that none expired on you, unless if it is there is no way you can prevent that. So first in, first out should be implemented. Newer stocks usually should be placed behind older ones, especially now in our supply, in the nature of our supplies. When you see newer stocks usually have higher, longer expiry dates than the older ones. But if, for instance, maybe your older stock has longer expiry date than the newer one, so you put on the newer ones in front, so that you should not finish your older stocks that has a very long expiry date. So full stock checks, you have to do stock checks monthly. While for high value agents like trastuzumab, pembrolizumab, you have to, those biologics, you have to do weekly stock count to make sure that all are available and there is no loss to storage or inventory. Quarantine near expiry items within 4 weeks. So it's very encouraging that whenever you have in your storage, you find out there is an item that is about to expire at least 4 weeks, 1 month. You then bring it out, or you place it somewhere where if it is going to be used, you use it, or you arrange it for timely return for disposal, or you return it to the main store, as if it is in a pharmacy unit or the constitution pharmacy, the constitution unit. You have to maintain accurate inventory with expiry dates and batch numbers for all your products. While for dispensing and transfer, as they are cold chains should be should be maintained. So use validated insulators, containers, cool boxes with ice bags for intra-hospital transport. For instance, if you are oncology store where you are storing the drugs, it's a little bit far from the oncology pharmacy or the constitution unit. So you have to use this specialized, containers to transport them within the hospital, so that excursions of temperature should be prevented. You have to also document out of cold storage, that is count against cumulative excursion allowances. You level prepared doses with preparation time, like the earlier presenter has emphasized storage conditions and also the expiry of that. You have to also, for word level cytotoxic storage, is strongly discouraged because at word it requires pharmaceutical grade refrigeration, so you cannot carry your cytotoxic to word where you store it on non-pharmaceutical grade refrigeration. Next slide, please. So now what can you do when there is a cold chain excursion, that is deviation of monitored temperature outside the accepted range specified for the stored projects? Critical, you should know, is you are not to discard or use potentially affected stock without formal pharmacist assessment. So these are some of the, the SOPs. There should be immediate response, assessment factors, and also you have to find out what are the root cause and also the prevention of further occurrences. So all immediate response is you have to quarantine all affected products. You level the date, time, minimum, and also the maximum temperatures. You identify the probable cause of, the reason, if it is power outage, if it is, technical issue with the refrigerator or the freezer in the case of where it has to be freeze. And also you retrieve complete temperature data log, because we made mention that our freezers should be monitored with temperature, with thermometers. So it is keeping record of those, temperature throughout the storage of such products. So you have to retrieve that data log and assess it. So the assessment factors, product specific stability data, like we made mention, each product have their own stability data. So you assess the stability data, look at the summary of product characteristics and see whether if the excursion has went beyond which level of excursion is it? Is it an acceptable excursion? The time, is it okay for you to for the assessment? You have to also look at the magnitude and duration of the excursion. You do some calculations, kinetic temperature calculations to know to also ascertain the magnitude. You also cumulative excursion history for batch from maybe from the time of the manufacturer to the time it reaches you. There is probably an excursion of temperature, so you have to calculate all, cumulate all the excursion history of the batch, and also manufacturer medical information. If required, you have to contact the manufacturers, especially in case of those highly expensive cytotoxic agents or the biologics. You can contact their manufacturers. For instance, if it is Ascertain, call Roche and ask what are the possible measures you should take regarding that. So you have to find out the root cause and also offer preventive measures that can prevent further occurrence. Next slide, please. Next slide, family officer. So for high-risk agents, these are some, storage references, post-reconstitution. Like an example, we made mention that, the storage condition for an intact vial or a tablet may differ from, when it is reconstituted or diluted. So this is like an example of storage references. One for paclitaxel, we made mention that the intact vial is between 15 to 25 degrees Celsius, and it should be protected from light. So post-reconstitution, it can only stay for less than 27 hours at 25 degrees Celsius in DEHP, which like I explained earlier, diethyl hexaphthalate pre-containers. So do not refrigerate diluted solutions because of precipitation. So when you already reconstituted paclitaxel, So for 27 hours that you keep it, allow it at room temperature between the temperature of 15 to 25 degrees Celsius, and do not refrigerate that so that you prevent the occurrence of precipitation. We also have oxaliplatin. It has to also be protected from light. We have cisplatin is there, the temperature is there, and at room temperature after reconstitution, they can all last for 24 hours at room temperature. But also, you should not refrigerate. You should not refrigerate it. It is very, very important not to refrigerate it. There is also, very important criteria that should be adopted, especially for our oncology reconstitution pharmacists. I know that when we have, a regimen for a patient that is to be, reconstituted for a patient, our first presenter made mention that in the level we usually use to indicate also, the rate of the administration of that drug. For instance, a patient is to receive a CAP regimen, which is cyclophosphamide, cisplatin, adriamycin, and fluorouracil. So if you, like we said, adriamycin is also light sensitive. So, and it isn't supposed to be the first to be, prescribed based on the sequence. I don't know if you have covered that, but definitely on hands-on training, you will definitely cover that aspect as part of the important, labeling that you labeled your reconstituted cytotoxics. So it is very important when transferring those reconstituted, for instance, we have reconstituted all the 3 drugs. When transferring it, we should notify the nurses that this so drug is light sensitive, so it should be protected from light while waiting for administration to the patient before the first drug administered finishes for the second one. So it has to be protected from light so that it should not be denatured or degraded. So in some advanced places, I know they use this specialized containers that can prevent those sensitive products from light. So trastuzumab is there. It should be freeze. So do not freeze trastuzumab. It's 2 to 8 degrees Celsius. Biology irreversible nature is frozen. So you don't also frozen them, but cold chain is very critical. We have pembrolizumab is also there. Do not heat. Stringent cold chain required. You also have to protect pembrolizumab from temperature, from light, sorry. We have liposomal doxorubicin. You do not freeze it because freezing causes irreversible lipid aggregation, which you cannot disperse it. It will aggregate. So it's very difficult for the constitution. Dacarbazine, the temperature intact is 2 to 8. But at room temperature, it can stay for up to 4 hours, for 4 hours at room temperature and 24 hours if refrigerated. But it has to be in amber bags when refrigeration and storing the reconstituted dacarbazine. So, and you see one beautiful thing for dacarbazine, when there is excursions, you see pink or purple discoloration, and also which is showing decomposition, and do not use it. So while I was an oncology reconstitution pharmacist, we made, there was a time, we do usually used to see this types of excursions or changes, but as a responsible pharmacist, whenever that you see changes in physical appearance of your product, sometimes it is the intact value you see those changes, while for sometimes it is from the reconstituted or leftover reconstituted product that you notice that. So we 2019, I started, drafting a book that is recording, excursions of cytotoxic agents. Like this is what you are expected to see And if there is problem where not to use, you see we also made mention of the changes that you experience and then recommend whether you use it or you do not use it. For there are some, quite sure, some of the products initially when we saw changes stations, but then later we found out that it is not all changes that are as a result of degradation, or they cannot be used. There are some situations whereby the integrity of that compound has not been compromised, so it can still be used. So yeah, it's still the book is still in process. I left oncology practice, but with collaboration with those in practice, still we will try to find out, those excursions and record them, so that for centers or for people that are pharmacists, oncology pharmacists, also doing it, when they experience similar situations, they will know what to do. For my own case, we have to contact it. I think it's one Sandeep. She gave us a training in at University College Hospital Ibadan, Sandeep, yeah. And she's from University of Chicago Teaching Hospital. I contacted her, and with some of the explanation, she was able to provide, a document they use, like the way we just presented this, the temperatures, allowable temperatures for post-reconstitution, the intact bile for almost like up to 100 cytotoxic agents. So I believe it is still in use in oncology pharmacy in Ahmadu Bello University Teaching Hospital. So probably if it is still available, we make it handy to centers that doesn't have such requirements. So next slide, please. So the regulatory frameworks, like all we have been discussing, they are from guidelines established. So these are some of the guidelines, like the WHO good storage and distribution practices that provides foundational international guidance. We have the ICH Q1A, which is for stability testing of new drug substances and products. We also have the USP, the NIOSH, which is for the USA, and then we have the CO COSH, which is for UK, is for occupational safety regulations for personnel handling cytotoxic agents. We also have the, the one my earlier presenter has presented, this Association of Health ASHP guideline in handling hazardous drugs in health system pharmacies. So there should be also local institutional policies. Always usually applies where more stringent than general guidance. So locally, you can create some of your policies of how you can manage some of, as far as it is not deviating from the regulatory framework or the regulatory standard, but if it is better and it has provided more control to the standard guidelines, so it is usually approved for general guidance. Next slide, please. So we also safety in cytotoxic storage. This has been, is one of the, major focal point of my earlier, Dr. Nafisa's presentation. And, all cytotoxic storage areas must be designated as hazardous zone with restricted access to trained personnel only. So this is so straightforward. Appropriate PPEs, that is gloves, gowns, must be worn when handling cytotoxic containers in storage areas. So you see, in all aspects of handling cytotoxics, whether you are receiving those cytotoxics, you are dispensing those cytotoxics, or you're constituting those cytotoxics, you have to maintain, PPE. You have to maintain safety for yourself, and for the cytotoxic itself, maintaining the temperature, because that is maintaining its own safety, and also probably spillage and the environment, like she made mention at oncology reconstitution. So spill kits must be immediately accessible in or adjacent to all cytotoxic storage areas Now we are discussing on storage. Please don't confuse the presentation with that of my earlier presenter. So cytotoxics must be stored in closed leak-proof secondary containers to contain accidental leak breakage. So if you have, containers like rubbers, if you can remember, I remember when Paluta comes in, it sits in one, secondary container. So also cytotoxic can be put in such types of rubber or secondary containers, but provided they have not compromised the storage condition of such, so that when there is leakage, it will easily be contained. Refrigerators used for cytotoxics must be clearly labeled with cytotoxic hazard symbols, our earlier symbols. So please, for those centers that didn't have, I know some will be putting Coca-Cola and some food. It is not supposed to be. So label it, please, so that it should be a deterring level for other staffs not to use those fridges, because hazardous substances are stored there. Pregnancy and fertility risk notice. This is a very, very controversial aspect. I remember when I was
This meeting is being recorded.
using the cap. So one present with some troubling conditions. So the other two will not be administered until when the patient is better, in a better condition to receive those two. So you have to store them for the patient. So making yourself very conversant with the product specific requirements, storage, and also for the constituted products is very, very important. So training like this are highly encouraged to use. So use an interpretation of temperature monitoring equipment. All the temperature monitoring equipment you should be able to, pharmacists should be trained on how
This meeting is being recorded.
I know if you are a reconstructing pharmacist, so maybe you should make sure that you bear that professional responsibility. There is nothing like I am assuming nothing has happened when you have excursions and you are contemplating on the cold chain integrity. Please don't dispense to your patients. You have to verify every product. Always consult the current summary of product characteristics, like we made mention earlier, especially
The recording has
for
stopped.
reconstituted and diluted preparations. You should also, take away today that document everything from your temperature logs, receipts, excursion reports, and assessments, these are very important, documents for medical legal records, like I made mention earlier. And where a product integrity is in doubt, please escalate it promptly. You quarantine it first, you assess formally, before dispensing. So you have to assess it. We have our SOPs there for, how you can assess it and how you can also prevent further occurrence of it. So remember, this is, a repeatable statement, starting from my OGA, the former chairperson of oncology, which she said, there must be training and retraining and retraining, you understand, in all aspects of oncology pharmacy. And also the first speaker has also re-emphasized on, training is continuous. You are never okay with the training, especially when it's because it's a scientific area and there is constant changing of knowledge. It's constantly changing. So you have to train yourself even in the storage condition, and also receiving of cytotoxic agents. Competency in cold chain management requires regular assessment and retraining. So the next slide. So here are some self-assessment questions. So please, you can reflect on these questions. If you were given the slides will be available, so you can look at them and see what measure will you take in such scenarios. The next slide, please. So here are some of the references, and for your further readings, all what you are expected to, what we look in making of the document, and also there are more and more informations there. This is just like, the tip of an iceberg. When you go in, you can read more and more on some of these processes that we introduced today. So thank you very much for having me. Back to my chair, the pharmacist, Dr. Ramatu, for your final and final submission. Thank you very much.
Okay. Thank you very much, Pharmacist Nafisa Yahuza and Pharmacist Umar Damusa. Am I audible enough?
Yes, ma, you are audible.
Yes.
Okay. We have come to the end of these presentations. But one thing I want to assure the participants is that you are hearing from the horse's mouth. You have heard from Fam Nafisa and Fam Damusa. These are people that have worked in oncology pharmacy for several years. So they are telling you practically most of the things that they do day in, day out. Most of the things that they have done, they still do day in, day out as oncology pharmacists for several years, except that Musa that left and now joined the Kaduna State University. But I can tell you that we have all worked as a team, and with Fam Suleiman and Fam Nafisa are still there up to today. Fam Damusa left to join the Kaduna State University since he needs to further his studies. But these are people that for several years work as oncology pharmacists in Ahmadu Bello University Teaching Hospital. So you are hearing in Abut, we have three units. We have the oncology pharmacy store, we have the oncology pharmacy dispensary, and we have the oncology pharmacy reconstitution. So those SOPs that you see them reeling out to you are the SOPs that you are going to find. You find a different one in our oncology pharmacy store for handling of those cytotoxic agents. When you go to dispensary, you find another SOP. And of course, when you go to oncology reconstitution, you find another SOP for you to use in all those areas. So I know that this pre-conference training has started over how many weeks now? And finally, what they are telling you is, if you have not started, please, you can start. And I want to encourage us that you can start very little. And you can always call all your colleagues in all other institutions. If you meet any stumbling block, in fact, how to set up the room, how do I even get, I've seen people call me, please, how do I even get a space in my hospital over the years? And we started from, this is the way to write your letter, this is the way to do it, So please, if you want to start, if you're a participant and you don't even have an oncology pharmacy in your hospital, this is telling you that you can start anyhow, just contact your colleagues, ask them, how do I go about it? And then you start. For every step where you meet any stumbling block, please call your colleagues all over Nigeria. They will be there to give you information, to help you out. All of us, we're still learning and will continue to learn these oncology pharmacy practice. So thank you very much. I will hand over to our chairman, Pharmacist Ijoma Okwesileze. Thank you very much. IJ. My chairman, where are you? IJ. Okay, since she's not here, maybe we could just start. I know the next thing with this training. I know she will join us later. The next thing that we will do is whether we have any question and answers or any comments. Please, if you have any comments or question, please can you raise up your hand? And Fam Damusa and Fam Nafisa, please, we should all be checking our chat boxes whether there are any questions there for us to answer. Please, any comments, any additions that you want to add to this presentation, any questions that you have, please can you raise up your hand, please?
Thank you so much, Fam Ramatu. There is a hand up. 048. Please, can you unmute and ask your question? So sorry, please.
Okay,
Network.
welcome back, my chair.
I've been struggling to join back. Thank you. 048, go ahead, please. Ask your question.
Good morning. Good morning, everybody. Thank you so much for this enlightful presentation this morning. I've learned a lot. I wanted to ask, at my institution, we are currently trying to set up our oncology pharmacy. And over time, we've heard over and over that it's important for the oncology pharmacy to handle reconstitution as against the nurses doing bedside reconstitution. But currently, my institution doesn't have the financial capacity to get all the infrastructure and engineering controls required to set up a reconstitution lab, a standard reconstitution lab. And people have been encouraging me that we should just go ahead and start with what we have. That is open air reconstitution and minimal PPE and all that. I want to ask, is it genuinely advisable to start that way? Or do I resist and place my foot down and insist that we must start with the fully equipped lab whenever that is possible, whenever that is achievable, because of exposure? So many people have tried to downplay the exposure, that these things are just being said for saying sake, and the consequences are not as bad as we think. What do I do in this situation? What is the advice OPAN can offer me in this situation? Thank you so much.
Nafisa, do you want to go?
Thank you very much.
Okay, Damusa.
Yes, let me yeah, you see, the first thing is like the first presenter, Dr. Napisa, made mention that wherever you are, wherever you see those facilities with biosafety cabinets today, started somewhere. They have started somewhere. Initially, in most of such facilities, you see nursings, constituting such, cytotoxic agents. So advisably, if I advise you, I think it's better you also start somewhere. Even if you are able to, retrieve, the constitution responsibility to the pharmacy is a win. That is number one. Then number two, I don't know, maybe probably if your hospital can provide you with, a single office like this, you can start with. Like I remember that is how we started in Ahmadu Bello University Teaching Hospital. We started with one small room, but very important, there should be a tap running water, and also maybe a table that you can seal using a very good nylon that will prevent contamination, something that you can clean on everyday basis when you want to work. Make the place only accessible when you want to constitute, and you can use the basic PPEs for start. before your hospital, you cannot just fold on your hands and say, no, we are not going to take the responsibility because my hospital does not have, the financial capacity to provide this biosafety cabinet or the required, area to build a required area. I remember, like she made mention in her presentation, we started. It is not a specialized, build area initially. It's just one small room that we were given in the oncology clinic. So we started there, and now where we are in ABUTH, we have they build a dedicated oncology reconstitution unit, and they provide all the requirements for successful or for safety reconstitution of the oncology. And the myths that people are saying that the exposures are not true. I know it is very true. So you have to be very, very careful with these agents. Many people, though it's not access, but there are people that has gotten, this disease condition from exposure. Not that they were taking the drugs. They are cytotoxics, and you are healthy. And if you didn't protect yourselves very well, I told you there is a study that we conducted in ABU Teaching Hospital where we found out exposure levels of cyclophosphamide in the urine of people handling this product. So it's very, very important you use the protective. You can start with double hand gloves, your N95, respirator, and also your head cover. If you can have a dedicated lab coat, even if they don't have the that disposable one, PPE, you can have a very dedicated lab coat, something you can wash and clean after use. And one important advice also for those that are going to be doing such type of reconstitution is you have to take very good care of yourself. Take a lot of antioxidants so that even if you get exposed to these agents, they can easily get cleared out of your system, or you can easily improve your immunity so that it won't have much effect. Your cells will be able to handle them. So it's not the exposure that is the problem, but there is level of exposure and also persist exposure. So to such cytotoxics that harmful level, if you are exposed to that harmful, that is what is. But for small exposure, you can be rotating so that you can be out of the unit for repression, and then somebody will take over doing that. These are some of the practices that were employed in Ahmadu Bello University Teaching Hospital when we were starting this oncology reconstitution unit. Thank you very much. I don't know if I have responded very well to your question, but if not,
In addition to that, thank you very much, Musa. Well said. In addition to that, you see this some of these sometimes the doctors, they don't want you, or the nurses, you as a pharmacist, to handle this. I've seen a doctor that told us that he has been handling this medication for over 30 years and nothing has happened to him. Yes, it might not has happened to him, but another person, it might happen to another person. So it should not be that you allow yourself to make it your fate. You understand? Like he said, or like a saying that goes around, protection is better than what. So it's very important that you protect yourself. You start somewhere, but ensure that you protect yourself. And then we mentioned medical surveillance over time. If there are many, some can be in the pharmacy. Over time, you rotate. This one move to the reconstitution where there is high level of exposure compared to when you are in the pharmacy, that you're just handling the cytotoxic, you're having a little exposure. So over a long time exposure is what we are talking about, not that because you are exposed 1 or 2, 3 times, long time, and then the level of exposure. So I think it's very key that you start somewhere with all this that you have today. Thank you.
Thank you
Hello?
so much, our wonderful. Yes, ma. Ma,
Hello.
please come in. I want you to say something. Yes, ma. We can hear you.
Yes, I thank you from Nafisa and from Damusa. But to the person that asked the question, I would advise you, apart from everything that they have actually said, please, over the years, we even started when Nigeria did not have a policy. The policy now came into circulation in 2021. So you have a booklet that you are being backed by the Federal Ministry of Health, saying that this is your chemotherapy safety policy. So I will advise you that I don't know if you can get hold of some doctors or your CMAC. Does that person work in a private hospital or a tertiary institution?
A
If
tertiary
you have some
institution.
tertiary institution, thank you. So you can go to your head of department, tell your head of department that you want to talk to them about chemotherapy safety policy. You finish from your head of department, you tell your head of department you want to talk to the CMAC. The CMAC will gather those specific clinical areas that uses chemotherapy. When they gather them for you, you make a presentation of what your chemotherapy safety policy is saying. And you gather the nurses together there. You will now inform them about chemotherapy safety policy. My sister, I'm very sure you will see some nurses saying we don't even know. All those that are interested, all those doctors, all those nurses that you see that are interested in reconstitution, by the time you tell them you need to do this, you need to do that, you will see that all of them, they will back out. They will back off reconstitution and leave it for you as oncology pharmacist that is your own, because you are the one that everything that Nafisa and Damusa has taught you today, you are the one that knows what your PPE looks like. Most of them, it was only after we told them that they felt, in my hospital, some of them said, but madam, you didn't tell us all these ones before. I said, when we come into the ward and we tell you, you think as if you want to take over your job. But there are risks to handling chemotherapy. So please, my sister, another thing you need to do apart from everything that they tell you is that make sure that your people are aware about the chemotherapy safety policy. In there, you have your role as an oncology pharmacist. You will see inside the policy there's the role of the oncologist himself and the nurses. Everybody has their own role. What we are saying is preparation and reconstitution. It's the purview of the pharmacist. By the time you finish preparing, you can hand it over to the nurses for administration. Even when they want to administer, be there to give them the chemotherapy safety rules, to say that please wear your double gloves, before you administer these drugs, and wear your N5 respirator, because you don't know what will happen. These things can be leaking, Pharmacists should encourage themselves by going to these nurses to tell them that, please, we want to talk to you about chemotherapy safety policy, so that everybody will have their roles. Now, in some hospitals, I will tell you how Damusa has told you how we started in Abut way back in 2015. That's about 11 years ago. Now, I will tell you how it was started in National Hospital. From Richard, I'm not sure whether he's here. By the bedside, from Richard is don't mind. I am an oncology pharmacist. He was going to the ward with the nurses. When it comes to reconstitution, you will collect those vials from them and reconstitute by the bedside what they are doing. It is the pharmacist that will reconstitute. That's the way from Richard and from Mrs. Clara Adeshola started, by the bedside themselves. They will do the necessary thing. Gradually, the nurses left it for them. It is not our work. Gradually, they were able to set up their own oncology pharmacy unit. So if you say you are not going to start from anywhere, you will never get it away from those people that are doing it. So start from somewhere. But please, before you start, call all your colleagues all over, Adamusa, from Nafisa, all of us, we're all over institution, and tell them what should I get to start with, so that you have minimal exposure for yourselves. And then later you now pursue your clean room, you pursue your biosafety cabinet and all other things. Thank you very much.
Thank you, Ma. Thank you, everyone.
Thank you so
Chairman.
much, our wonderful presenters. Yes, for that answer to that question. I want to add that the most important thing when Damusa was speaking, he kept on emphasizing, please ensure that you protect yourself. Because I, for one, I will not be the one to send you to go and start exposing yourself to hazardous drugs, that will harm you, later in future, maybe in the next 10 to 15 years. So for us, I've shared this experience before that for us in my center, my team even refused to start bench reconstitution. They refused. So what I did was, I've said it before, the first thing you need to do is to do a hospital seminar. You need to educate your hospital staff. I'm sure that in most hospitals, there is always a day for hospital seminar. Departments used to pick a date to present. So prepare a presentation on chemotherapy safety for your hospital. You will be surprised that after your presentation, they didn't know all the things you will tell them. They didn't know about it. They didn't know how dangerous it is, exposing themselves to micro doses of those hazardous drugs. Because even in the world, you see the nurses putting these drugs in the same fridge they put their food, they put their water. They did not know. The first time we did that presentation in my center, then we didn't have a chemotherapy bay then. So the cancer patients were still receiving chemotherapy in surgical wards. The nurses refused that they will not put chemo in their refrigerator again. In fact, if you come near them with refrigerator, they will just get up and leave you and say, no, don't come near me. I didn't know that this drug is so toxic like this. And we've been exposing ourselves. So do a hospital seminar on chemotherapy safety. Then when you finish that, I'm sure by the time you finish that, you go through your HOD like Famrama to advise, meet your CMAC, then you'll be able to see if there is any biosafety cabinet somewhere in your facility. I've said it that microbiology department, they used to have a lot of biosafety cabinets because of the nature of their work. So I'm sure you will find one that they are not using. Maybe they kept it aside because the UV light spoiled or something minor spoiled. Check it and see whether you can work on it, apply for funds. The bioscientist in your center can refurbish it for you, and you can start with that. So that later, then in addition to that, make sure you have your PPE, which is the last line of control for exposure. Make sure you have your PPE. It's very important. Double gloves, your gowns, your goggle, then your N95 respirator, like we were taught. Very, very important. Then you can start with it. Then in future, by the time they see what you're doing these days, we are talking about clinical trials in oncology. That's what Federal Ministry of Health is pushing for. And for those clinical trials, for you to be involved in clinical trial, you must have all those things in place. Standard, your biosafety cabinet must be certified. Those things will come with the clinical trials, and you will see where your center will get a brand new biosafety cabinet because you're already there. They have a trained oncology pharmacist already. So don't lose hope, please. Start from somewhere like they said. Thank you so much. There's another hand that is up. Please, can you unmute and ask your question, please?
Yes, thank you. Good morning, everyone. And thank you for the presentation. So
please, the attendance link is on the chat box. Please click on it and fill the attendance form. Thank you. Continue, ma.
Okay. So I'm asking from the perspective of a private institution, a private facility. As pharmacists, we are not with the doctors reconstitute, and we are in charge of the supply chain, making sure the drugs are available for the doctors to reconstitute when they are ready. And it has been that way all the while I was there, even after I left. So, but my question is more about the way how the drugs that remain after a particular after reconstitution. So let's say paclitaxel remained with or you were consuming pacli and cabo, and it's you didn't exhaust everything in the vial, and then you keep the remaining of what was left in the fridge. And then for another patient, I don't, maybe sometimes after like 2 or 3 days, whatever the remnant of what was left before will still be used for the next patient, just because they're trying to save costs or save, I don't know now, but you usually in some cases still use what was left from the old vial for the next patient's reconstitution. And I didn't think it was okay, but that was what we were told to do. And we used some of them like that. On some occasions, I won't agree to use it. If it was past maybe 3 days, I won't use it. But if it was still within 48, 72 hours, we were told to still use them. I wanted to know if that's okay, or is this supposed to be so? And also for private facilities, they've not seen the rules for oncology pharmacies, because they have some don't even employ pharmacists at all. They just put somebody in the pharmacy to just make sure that drugs are available when they need them. And I don't know how we can, change that. So that's my question. Thank you.
Thank you so much for that question. Well, I know most private cancer centers in Nigeria, like Lakeshore, Marcel Road, Asiugbo, they have oncology pharmacists, and the oncology pharmacists are reconstituting their drugs. I'm sure you are talking about normal, not cancer center, not private cancer center, not specialist private clinics. You're talking about just private clinics that treat all manner of patients and are also
It's
treating
actually a
cancer
cancer
patients.
hospital in Abuja. Actually a cancer hospital in Abuja. Yes, ma'am.
Wow. Wow. Well, the ChemoSafe policy is applicable to everybody in Nigeria, both private and public hospitals. And the way they want to go about the implementation is because we are pushing for a review of how far, because the policy was launched in 2021 and this is 2026. The last International Cancer Week, we had a session on that ChemoSafe policy, which I moderated. And one of the things out of that session was that the government should, do a follow-up to know the level of implementation and then what next. And part of the things we recommended is that facilities that are not complying with that policy should not have any business giving chemotherapy. They should not be accredited to treat cancer patients, because what you're doing is that you are exposing the public to, hazardous drugs. And all of us know the danger of that exposure over time. So, no wonder the cancer burden is even on the rise. Nobody knows whether that's part of why we are where we are in terms of the prevalence of cancer in Nigeria and even globally. So, what I'm trying to say is that the policy is for everybody, but in Nigeria we like cutting corners, and the private hospital is trying to minimize the expenses, because paying an oncology pharmacist will increase the cost of running the hospital. So they will tend to, it's not even only in the pharmacy section. You will see one doctor doing everything, both the one that he's specialized in and the one that he's not specialized in. That's where we find ourselves in Nigeria. So that's the challenge. Then coming to the second part of your question, what was that you said? The second part, what was the second part of your question?
So I said that sometimes the drugs would remain. Yes.
Thank you. Yes, thank you. In fact, it's because of this issue you raised now. That's why OPAN decided to come out with the Oncology Pharmacy Practice Manual. In that our manual, you will find the stability chart. I was happy when Famusa was presenting, he emphasized so much on individual drugs. There is no, how do I put it? It's not, how you handle it is not uniform for all the drugs. It depends on which molecule you are talking about, which agent. So the stability for at room temperature for open vial for paclitaxel is different from that of carboplatin, is different from that of cisplatin and all that. So for each of the drug, you need to check the stability chart to know what to do. Whether you will be able to reuse the open vial, whether you will be able to store the infusion, the diluted drug, how long can it stay, at what temperature can it be stored, can it even be refrigerated at all? Musa told us that you should not refrigerate reconstituted oxaliplatin because it will crystallize out and precipitate. Do you understand? So
Yes,
what
ma'am.
it means is that is not, you cannot just come and say when you open a vial, oh, after 24 hours, you can still use it, but you cannot use it after 7. No. And let me even tell you, the general rule is that any reconstitution, any vial that is opened without closed safety transfer device should not be used after 24 hours. That is even the standard rule. If you do reconstitution, you do not use closed safety transfer device. You are not supposed to use both the open vial and even the infusion, the infusion bags after 24 hours because you did not use closed safety transfer device. And mind you, in Nigeria, apart from in 2021, when we did training in Lagos, that they trained us with the closed safety transfer device, I, for one, I was looking for where to buy it. I didn't see. But thank God that the people, our partners for the hands-on training are coming with the closed safety transfer device. The JNCI is now, they now have those devices in Nigeria, including infusion pumps and all manner of things for chemotherapy reconstruction and chemotherapy administration is now available in the country. That's why they are coming with it to do the hands-on training for us. So you can actually have access to them now. So if you use a closed safety transfer device, when you open that vial and when you did your reconstruction, the storage is different from, it will give you, you will be able to store it longer than when you is expensive. So I'm sure that most facilities might not even be able to afford to buy it. And when you are using it, it will increase the cost of chemotherapy for your patients because you build the cost of those things for your patients to pay. So at the end of the day, we might not be using it. I don't know, maybe the private cancer centers that have the 1% of the 1% patients that can afford any amount you give them. But for most of our patients that are indigent, they are even struggling to pay for chemo. Yeah. When you now come and tell them that to administer, to reconstruct the chemo, they have to pay maybe up to 50,000 just for reconstruction because of the device you're using for the reconstruction. So at the end of the day, it might be difficult. So what I'm trying to say is that make sure you have the practice manual when it's launched in Abuja, because all the questions about the stability, the beyond use dates, how long will the open vial be stored, how long will the reconstituted solution be kept, and all that is there, including the references for further reading. So they are there. And then all the SOPs that they mentioned, including the competency assessment test, and everything is in that book. And by the grace of God, we will launch it during the conference and make sure you get a copy for yourself and for your facility. Thank you. Please, Tim, you can please answer the questions too. I just said, let me add you can add to the answer for her question, please.
Hello? Yes, Tiama, I think you have done justice to the question. But one thing is at private hospitals, usually the doctors that are there.
Your experience.
Hello?
Her hand is up. Okay. From that, Musa, go ahead so that Dr. Onodugo her hand is up. She wanted to say something. Yeah.
No, I just want to give a scenario. Most of the times it's not, it's not, it's the system. Or sometimes the doctors don't know the capacity of pharmacists they have in private hospital. There was a private hospital here in Kaduna, and I just went to, there was one contract issue that I went to the pharmacy, the hospital pharmacy, you understand? It's a private hospital, very big one. So at there, I saw one consultant doctor, oncologist, which we worked with we work a lot with in ABUTH. Once he saw me, he said, are you there? I said, are you here? I said, yes, sir, I used to. And you're allowing us to constitute by our bedside, because he knew what we have been doing in, ABUTH hospital. It even reached a time when if he wanted to dispense or sorry, prescribe something, he has to consult some of us that how do we do this? How do we understand? So I think is the pharmacist in the private, most private hospitals that are enclave I will use that word enclave. They don't, bring themselves out. So for such participant, please, what you should do is you can also use the answer given to the earlier, participant that asked question. There are guidelines, and you can also conduct seminars like the way the chairperson recommended, show the importance of pharmacists handling this practices. And yeah, just now that we are doing this, a research idea just comes into my mind. I think it should be a very good supporting document if we were able to conduct, systematic literature review to see, if there are oncology staffs that reported cases of oncology staffs coming down with cancer cases. So if we do a systematic literature review, and with this, most of those nurses or doctors that are constituting thinking that it is a myth when it comes to, the toxicity that we were saying, they will definitely, deter them from subsequent. Most of them, they are not knowledgeable about it, and they have not seen it in real. Maybe their friend come down with the cancer. If it didn't come back today, tomorrow, maybe one time in their lifetime, it can come. So maybe research work like this needs to be conducted so that it can be a supporting document in trying to take the responsibilities of reconstitutions. Thank you very much.
Thank you, sir.
Go ahead, Ma, your hand is up.
Yeah, good morning, everyone. I just wanted
Good
to make
morning.
a couple of suggestions. In Nigeria, sometimes implementation is, in fact, not sometimes, all the time, the problem is implementation. We have beautiful laws, beautiful guidelines, that can stand scrutiny at any level. The problem is always implementation. And so sometimes bringing out the big hammer doesn't really work because, our systems are, sorry to say, corrupt in more ways than one. So even when you're saying hospitals that don't have oncology pharmacists are not allowed to, some people will go behind, give money to somebody, and you would see that that hospital is licensed, registered, or whatever. So I think that particularly the example or the particular hospital that the other participant was talking about that is based in Abuja, that is a private cancer center and does not employ a pharmacist. She's not even talking about oncology pharmacist. There is no pharmacist there. People should think about advocacy. Is there a way to get the name of the hospital, special invitation to the MD of that cancer hospital, recognize him on the table, and in all that you are saying, put in all this in, I don't know, both the person doing the keynote address, everything that is going to be spoken to the public, there must be an underlying paragraph somewhere in there that talks about the ChemoSafe policy and will I say, the reason why oncology pharmacists are a must in any cancer hospital. Even something like this flex banners in that your conference, can we have one that says, why an oncology pharmacist? At the entrance of that hall or somewhere that eyes would see it. It doesn't cost too much. And you detail the reasons why, So I'm saying that we need to do a lot more about advocacy. But this particular hospital and any other one, particularly in Abuja, that is known, that does not employ pharmacists or don't even employ oncology pharmacists, let's do advocacy. Give them special invitation. Put them on the high table, my dear. If that is what will survive, that will, or at least recognize them. If that is what will make it work. So that's the thing I wanted to talk about. The second thing was that, is it possible for OPAN to actually do a survey of all the centers in Nigeria offering oncology care? And how many of them have pharmacists in the first place? So Then how many of them have oncology pharmacy? That's a very good research topic that should be pushed and published. So the ones that have pharmacists, what are their qualifications? Are they specialized? Do they wish to be specialized? So those kind of things are the kind of things that can also that can help to push policies that will further, specialization of pharmacists into oncology care. I don't know whether what I've said makes sense, but that's just what I wanted to put out there. Thank you.
Yes, my great thanks. Yes. Thank you so much for that wonderful suggestion. Yes, advocacy. That is true advocacy that we are here today. You also the letter that the federal ministry gave, to support our conference. It was through advocacy that we were able to get that letter. We were able to get that recognition and that backing from the ministry. So we are making progress. Rome was not built in a day. We'll keep pushing and keep advocating. That's why we are asking people to come and join us, because this is not what one person can achieve. Together, we'll be able to make more impact. We'll be able to make more progress. We'll be able to make more, establish the standard of practice in every hospital where cancer patients are being managed in Nigeria. Thank you so much, ma'am, for that wonderful suggestion. There are questions on the chat box. I don't know how many they've answered when network threw me out. Hello? Ramatu, were you answering questions on the chat box before? So that we'll know where
not
to
yet.
continue.
Maybe we should start that
No,
now.
no, I have seen some of the questions were addressed by some of the participants, and
Okay.
and they are very okay. Yeah, there is a question. Yeah, let me go through it, even though they have been
Start
addressed.
from the first one, please, so that we'll not miss anyone.
Why is domestic? Why is domestic refrigerator not acceptable for use? Solar panel pharmaceutical grade refrigerator without battery, can they be used for the storage of cytotoxic agents, since at night they lack power? And for how many hours or days are cold chain cytotoxic agents left on the tabletop at room temperature still considered safe, potent for use? So this
when
question,
you read one, I think we'll take you one after the other. So just read one, we answer next. So
they have been addressed some of the question. Like the first one, why is domestic refrigerator not acceptable for use? It has been answered. Yeah, you don't have, for domestic refrigerators, it has been answered. The temperature, ranges are not well controlled. Monitoring is not there. And also you cannot maintain, the conditions across the shelves of the, fridge. For such, that is why they are not used. So solar panel.
I learned that domestic refrigerator, because most of the refrigerator we have in the hospital is a domestic refrigerator.
Yes.
In fact, I tried to monitor the temperature. I discovered that it cannot even maintain 2 to 8. That is even the first thing. So most of those biologics that you were supposed to store at 2 to 8, and you put them on that normal refrigerator where you put normal cold chain drugs, it doesn't maintain 2 to 8. So until we were able to get the pharmacy refrigerator that can maintain 2 to 8 with an inbuilt temperature log and even humidity monitoring device, you monitor both the humidity and the temperature. So thank you for that answer.
So the second is for solar panel pharmaceutical grade refrigerator without battery. Can they be used for the storage of cytotoxic agents, since at night they lack power? So they are like pharmaceutical grade refrigerator powered by solar, but no, power storage. And the person is asking whether if they can be used. And I believe the only answer here is you have to assess it. We have made mention of assessment. Assess, the temperature log.
Because in the night there is no power.
There is no power, so you can.
No power in the night, so you cannot be used. How will you now maintain the temperature?
Maintain the temperature, yes, it's not possible.
But if it's a solar powered refrigerator that has backup battery, so in the night without sun, the battery will now continue to power the refrigerator. Then you can use it, but without battery, no, you can't use it.
You can't use it in the night. So for how many hours or days are cold chain cytotoxic agents left on the tabletop at room temperature still considered safe, potent for use? So I like, if you have listened at the presentation, what we said is that for such products, all the products that are cold chain, maintained, the cold chain should be maintained throughout from the manufacturing up to the patient bedside. So there is no specified days or hours that you should leave a cold chain intentionally on the table. Because for some products, some standards guidelines, specified the time. Like for instance, I told you while receiving receipt, it should not be more than 15 minutes. You should be done with receiving everything and transfer immediately to the refrigerators for storage. So I don't know if you're adding something for that.
Is to find out the excretion time for each molecule. There is always there in the literature. So you know the temperature excretion. Yes. If you are using ice packs, because sometimes depending on where your refrigerator is and where your reconstruction room is, or maybe where your chemotherapy bay is, you might need to use ice packs to maintain the cold chain in when the drug is on transit. So you need to know the temperature excursion, because when you're using ice packs, of course, it cannot be 2 to 8, but you can still put your temperature log in the cooler and be able to monitor the temperature. Some temperature, 2 to 8, they might have degrees or 10 degrees or whatever, depending. So always check.
So this one has been addressed. Most of the questions are addressed. So,
hello,
Damusa. Okay, ma. Yes.
Sorry, I just want to add this. That
what is the temperature excursion that you should not exceed 10 minutes maximum?
Okay, you have mentioned transportation really, but that at any point in time when you receive your cytotoxics from wherever it is coming from, please, pharmacists, oncology pharmacists should please check. Sometimes some very good company like Roche will come even with a temperature log for you so that you can monitor those temperature. So that when you see any temperature excursion or you see any deviation, you can reject the product. If you know that the cold chain is not being maintained, or you cannot vouch for the fact that the cold chain is being maintained from the manufacturer through transportation to your place, you can reject the product once you look at the product. But if you look at, some will even put the temperature log for you to check when you get to your place. So when you receive your product, please check the temperature log that that your product comes into your facility with. Another thing is talking about the solar refrigerator. You know, the solar refrigerator with the battery that we use, that was produced for the NCAP, that was given for the NCAP, came with a temperature, a thermometer, will I say. So each morning, that's what we do in my own oncology pharmacy, in our store. Each morning, we will check the temperature. And then when we want to close again, we'll try to check the temperature, so that you know that by the time you go home and come back the second day, you'll be able to know what has happened between those times that you people are not even in the facility. So that thermometer is inside the refrigerator and it should be monitored. And so you have a sheet where you do your temperature, take temperature 1, take temperature 2. And even if it is possible, you take temperature 3, if there's somebody that can allow you, and so that you can compare those temperatures. And you will know at any point in time when something is wrong with your refrigerator or with your solar refrigerator at any point in time, if you take the temperature regularly. Thank you.
So the next question is for cytotoxic drugs. Example, docetaxel. What is the stability when open and when to use for another patient? I think this has been addressed by the chairperson, pharmacist IJ, during some of her comments. Let's here are some still on solar panel. Can solar panel pharmaceutical grade without batteries be used? So it has been answered. And for how long can a cold chain cytotoxic agent be left at room temperature? This one has also been answered. Is cancer treatment limited to tertiary institutions only? Chairperson, maybe you can address this, but it has been answered already on the chat. But if you can give more.
Yes. Cancer treatment is not limited to tertiary hospitals only. The only thing is that the Federal Ministry of Health has adopted the multidisciplinary team approach to cancer care in Nigeria, and this is a global standard. So what it means is that they are now discouraging doctors from diagnosing and treating cancer alone. You must have an MDT, and you must have the full complement of an MDT. And what it means is that you don't even need to have those people working with you in your hospital. You can do virtual MDTs for your patient. So even if you don't have an oncologist working in your hospital, you can have an oncologist join your MDT even from abroad, like we do in our centers. So you can have a pathologist, you can have an oncology pharmacist. I've joined MDT for a patient in Lakeshore. I don't work in Lakeshore, but I was invited to join that MDT. I've joined MDT to review patients in so many places that are not my primary facility. So it's not encouraged for one person to diagnose and treat cancer. So you should make sure that you have a full complement of MDT to review your patients and then design the treatment plan for that patient. The outcome is usually better from practice and from experience. That is the standard of the Federal Ministry of Health for cancer care in Nigeria, and that's the global standard. So I don't know if that has answered that question.
Thank you. Yeah,
From that, Musa, any other question on the chat?
Yeah, the last one I can see here is he said probably it looks like a comment. I work at a secondary healthcare institution, so not a tertiary, and I would like to set off an oncology pharmacy at my center. And I say this is this is the starting point. Now you have seen how you can start off an oncology pharmacy in general, including the storage, and also the reconstitution, and also the pharmacy dispensary itself. So this is a very good starting point for you. And from the discussions we had today, we have discussed many ways by which you can start that. A secondary health facility, as far as if you have that oncology center, and oncology patients have been catered for, you have the necessary, like the IGA said, the chairperson said, if you have MDT in the hospital, so it's, I think, very big time for you now. This is the right time to start that. Yeah, thank you.
Thank you so much. Thank you so much, our wonderful president.
So this is the end of.
Any other questions, sir?
No, these are all the questions now. But I think I saw one hand.
Is there any hand?
Yeah, I think I saw hand.
Okay.
But
there's a hand up.
It looks like that. Yeah. Okay, maybe they put the hand down. It has been addressed, probably, the question.
Okay.
Yeah. So no hand.
Please, if you still have any question, you can ask now, because yes, today's session is very important to us, because when we were designing the curriculum for this training, our goal was, Hello, can you hear me, please?
Yes,
yes,
we can hear you. Yes,
okay.
We can hear you now.
Network threw me off again. So please, if you have questions, you can always reach out to any of us. One of the things we do in OPAN is we do mentoring too. We mentor our colleagues that are coming up, because we remember, how we started. We had the support of some of our seniors that were there before us. When Pam Damusa was speaking, he mentioned Dr. Sandy. Dr. Sandy is an oncology pharmacist from University of Chicago. She was part of the team that trained us at University College Hospital in Ibadan when we did training there in 2018. And one of the things that made me to, decide to build my capacity in oncology pharmacy, was the way Hello, sorry about that. So I was speaking about the training we did in UCH Ibadan. Hello, can you hear me?
Yes, we can hear you, even though there's an echo.
Yes,
It's
I'm
like you have
trying
two
to.
devices. You have the devices on, so maybe
I was using the other
you
one
can
as a
silence
backup.
one.
Yes, let me do that. Thank you. So I was speaking about the training we did in 2018. The Dr. Sandeep that Famuma mentioned, that gave him the stability chart that he was using. Famuma, we are interested in that book you were writing, please. I'll reach out to you later, so we'll see where you stopped and see how to collaborate with you. Anything that can help support our practice, we encourage it a lot.
Yes, okay.
Yeah.
Yes.
So when I think her name is Dr. Famramatu, you remember the medical oncologist that trained us in Ibadan? She spoke so highly of Dr. Sandeep. Dr. Sandeep is an oncology pharmacist from University of Chicago. She was part of the team that trained us. In fact, she told us that she cannot do without Dr. Sandeep. She said that she cannot even manage any patient without Dr. Sandeep being there. She cannot even dare to give any chemo to any cancer patient without doctor. The way she was just talking about Dr. Sandeep, I now asked myself, how can a pharmacist be this important that a doctor cannot function well without her? I said, no, I must build my capacity in such a way that my doctors in my facility will look for me when they want to manage a cancer patient. And by the grace of God, that's where we are now. And that is why we are doing this training. So we hope that pharmacists will, begin to take their place in the MDT, in their centers. Build your capacity. Take it one day at a time. Don't be afraid, Thank God for this manual we are bringing out. It will give you the confidence and give you, help you to know what to do. The guidelines, the SOPs, you will be able to follow it and know what to do. Thank you so much for joining us today. I don't know if there is any other contribution and any other comment. If not, we invite the Vice Chairman of the Faculty of Clinical Pharmacy, West African Postgraduate College of Pharmacists, to make a closing remark. Like we all know, this is the last session of the virtual part of this training. The hands-on training will be on 11th in National Hospital, Abuja. I hope to see all of us there, please. Please just try and come. I know it's not easy, but try. Now, the hands-on training will start by 9 a.m., hopefully. So we expect people to be in Abuja. Those that will be coming from outside Abuja, like me, I don't stay in Abuja. So I have to come in on 10th so that I'll be able to be in Abuja on the 11th morning to join the hands-on training. So our partners for that training, they already introduced themselves to us. We saw all the things that they are coming to do. They will be there physically with us for that training. So please come with all your questions, because I noticed most of us wanted to ask them questions that day. I said, no need. Just come with all the questions so you can ask them face to face. Then our team in Opan that are also ready to handle the hands-on training too. They've been working on that. Fambulus from Abut is leading that team. So they will be there too to handle the hands-on training. And all the facilitators will also be there. So in case you want to ask any of them questions one-on-one, they are also there. Make sure you collect their phone numbers for future mentoring and for follow-up. When you are starting your own practice, you can always reach out to any of us, to be able to help you. So thank you so much. I will drop more information about the conference and about the hands-on training on the training group. If there's any information, I will drop it there. You can also reach out to me directly if you need more information. So, Dr. Chineye, please, over to you, ma.
All right, thank you so much, Fami Joma, and all the facilitators of this very, very wonderful training that we started on the 13th of March. We've been at this training for more than a month, and I would like to salute the resilience and the determination of all the participants who have stayed. You know, sometimes it's easy to start something. It's also easy to fall out by the wayside before the end. So I want to salute your resilience, all of you who have remained steadfast. It also goes to show how hungry you are. Do better by your patients. The passion that you have to make your practice relevant. And I know that as long as you have the passion and you have the determination, where there is a way, will, they say there's always a way. So we know that good news from all the participants that have taken part in this conference. We're going to hear wonderful things about the strides that you're taking. Those who want to start, those who are already there, who are trying to be better. We're looking forward to hearing all the good news. And I know that when the good news comes, that Fami Joma will not hold it to. They will share it with WAPCP. Yes, they will. Yes, they will, because we're all part of it. You know, I always say that I'm an associate member of Open, whether they like it or not. Yes, because we started this. Yes, we started these trainings 3 years ago, isn't it? You know, at the first time, it was like it wasn't going to happen. But you see, somehow God has continued to help us. Every year, we are back doing more and doing better. So I would like to thank you all. We've gone through so much. To recap, is it the cancer, talking about the cancer cell biology and genetics that many people run away from, but was broken down in small bits for everybody to be able to understand and digest? Is it the cancer epidemiology and risk factors? Or is it the diagnostic principles for pharmacy? Or the clinical therapeutics and pharmaceutical care and all that, the systemic anti-cancer therapies, protocols, emergency care, supportive care, and so on, and the waste management and all that, and then capping it today with setting up, because we've laid the foundation, we've given you what you need, and we're asking you to run with it. Please run with it. I always tell my students everywhere that it's not to gather knowledge. It's okay to gather knowledge, but knowledge that is gathered and that is not put into practice is useless and will fade over time. So the best thing you can do for yourself is all that you have learned over this almost 2 months, 1.5 months or thereabout. Please begin to put it into practice. Don't wait for tomorrow. Don't even wait till the next, the hands-on. The hands-on is a different ball game. Yes, it's going to help you, but the knowledge you've gained, you can actually begin to put it into practice now. So start tomorrow. Start today. Don't wait. Don't put it off. Procrastination is the thief of time and talent. So please, don't put it off. Start today. Start small. And don't be discouraged if what you're trying to do is not welcomed at first. Like they have told you, Dr. Ramato has said, all the presenters have shared their experiences one way or the other. At the beginning, it was not always a wide welcome hands, but they kept at it. And today, they are where they are. So please start. Even if they don't listen to you, don't be discouraged. Continue pushing. One day you will break through. One day your knowledge and your passion and your determination will be seen and will be rewarded. And that is what we're saying from the Faculty of Clinical Pharmacy. Please put it into work. Put it to work. Start today. Start small. Don't give up. Don't give in. Don't back down. Don't back away. Keep pushing. And I know that at the end, we'll be richly rewarded. Thank you so much, everyone. and God bless you.
God bless you too, ma'am. Thank you for all the collaboration, all the support that WAPCP has given us. We were so delighted when the oncology pharmacy specialty residency, was commenced by the college, and that has further given us the empowerment and the backing we need, because there is nothing like being certified in what you're doing. So if you are yet to enroll in WAPCP for your residency training in oncology pharmacy, please do that. Unfortunately, I think this year's enrollment has ended, because I think
yes, it ended 31st of March. It's next year.
31st of March. So it's next year that they will have when do the enrollment, where does it know the opening? Is it from January?
You can start no, you can actually start once the exams are done. So you can start in December, and it's online.
Okay.
It's online on the college website. So you don't even need to go anywhere. You just go to the college website.
How many years post-graduation? I think it's 5 years.
No,
because
3 years.
we have final year students here, so I want them to know what
it's 3 years, not 5.
Okay, 3 years post-graduation before they will be qualified to do the residency training. Okay.
Yes.
Another thing I will advise you is, if you're doing your residency training in oncology pharmacy at the college, please make sure you're doing the residency in a facility that has a functional oncology pharmacy practice, because that experience, that hands-on experience is very important. Like Dr. Onodugu said, she said, it is good to acquire knowledge, but if you acquire the knowledge and you are not practicing it, that is useless. And with time, you will tend to forget what you've learned. So even if you have someone that, is a trained oncology pharmacist, but is not practicing, it's not enough for you to say you are doing your residency in that center because the person is there. There is nothing for you to learn. So look for a center where they have a functional oncology pharmacy and be able to, have that hands-on experience there. That's when you will be able to learn. Thank you so much for joining us today. We thank God for the privilege to have this virtual training session, and we hope to see all of you in Abuja on 11th. We pray for joining messages for everybody.
Sorry, please. I forgot to remind us of the assessments.
Yes.
Which is mandatory, please.
Somebody asked about it. When will the certificate be given? Be ready.
I've answered them. I answered them on the platform. I told the person that is after the assessment. So please, when you've gone to Abuja and you've come back and you've rested, we gave you time to rest and review your notes. You take the assessment. It's mandatory. Without you taking the assessment, you won't get certified, please. So that's important.
So the assessment is on 15th. The information will be dropped on the training group too. And then another thing I want to mention, I promised at the beginning of this training that there is a bonus training package that we designed in collaboration with BVGH. So I'm going to drop the link. It's free. You're not paying any money. You just click on the link I will drop, then you register and do your pre-test on that platform, and then do the trainings at your own pace. The topics were also similar with the topics we use for this training. So it is like a bonus, like I said. So you do the training, then you do your post-test. You will also get a certificate from that training. The training is open/BVGH. So I'll drop the link on the training group for anybody that is interested, for further reading and to learn more and build your capacity more. You can go ahead and do that. And then if you're an OPAM member too, our website, you have resource materials on our website too. You can always access anytime you want, for further reading. Thank you so much for joining us. We pray that God will give all of us journey mercies as we plan to, be in Abuja for that hands-on experience on 11th. And thank you so much. I will see you guys there. Bye, everyone. And have a nice weekend. Yes.
Bye.
Thank you. Bye.
Yes, if
And
there are
well
more
done, Chair.
questions, yes, you can
Yes.
drop on the training group. I will always answer. If you
Yes,
have
thank you
more
very much,
questions.
all.
Thank you very much.
Yes, thank
Mama, well done.
Well done. Well done,
Thank
ma.
you.
Thank you.
Done.
Thank you.
My
Thank you,
chair.
everyone. Yes,
I
ma. Dr. Williams.
done.
Yes,
Bye.
ma.
Thank you, everyone. Bye, everyone. Thank you. Bye.
Yes, bye,
Dr.
ma.
Lidigo,
Bye.
well
Dr.
done.
Robert to my
Bye.
sister.
Well
Thank you
done.
so
My
much.
friend, how do you go?
I'm not too go.
I hope you are fine.
By God's grace,
Well
God is
done.
helping. Yes.
Oh, how is the family?
Congratulations,
Well,
WAPCP
fine.
Local.
Yes. Thank you.
Thank
Bye,
you.
everyone.
Thank
Mhm.
you. Bye-bye, my chair. See you later.
Yes, ma. We'll see you later. Yes.